There are four fascial compartments that separate and contain the muscles of the lower leg from the knee to the ankle. These compartments usually have nerve and blood supplies separate from their neighbors. The same nerve will generally supply all of the muscles within a compartment. From a functional point of view, the leg can be divided into two compartments and are each made up of antagonistic muscles. The anterior compartment is made up of the group of muscles that perform foot extension, while the posterior compartment is formed by a group of muscles that perform flexion of the foot. The intrinsic musculature of the foot is responsible for providing stability during orthostasis as well as ambulation. These muscles include the muscles of the dorsal aspect of the foot, the extensor muscles, and muscles of the plantar aspect of the foot, the flexor muscles. Unlike the upper limb, the lower leg is innervated by two independent plexus, the lumbar and the sacral plexus. As the branches of these nerves travel distally, they divide. When they reach the ankle, this division results in a total of 5 branches innervating the foot. These 5 branches provide sensation and direct mobility of the foot. For a memory aid, keep in mind there are 5 nerves, one for each toe. When these nerves descend along the lower leg, they cross the ankle, following the path of the muscles they supply. The peroneal nerves descend through the anterior compartment and go towards the dorsal or anterior aspect of the foot, while the tibial and the sural nerves descend posteriorly and innervate the sole. The saphenous nerve, a sensory nerve, and a single distal branch of the lumbar plexus are located on the medial aspect of the respective ankle. It is important to remember the position of each of the nerves that innervate the foot, since they will be responsible for the sensory and motor innervation of their respective compartments. We must memorize the role played by each of the nerves in their respective compartments. In the anterior compartment, the deep peroneal nerve will provide predominantly motor innervation while also collecting part of the cutaneous innervation of the dorsal aspect of the foot. The superficial peroneal nerve is a purely sensory nerve from the ankle and is responsible for collecting the sensation of most of the skin on the dorsal aspect of the foot. In the posterior compartment, it is the tibial nerve that provides flexor function as well as collecting all the deep and superficial innervation of the sole. The sural nerve is a purely sensory nerve that receives the sensation from a small area of the lateral aspect of the foot. The tibial and deep peroneal nerves are the only 2 nerves grouped in a bundle. These 2 mixed nerves have involvement in the motor proprioception and deep sensory innervation of the foot. In this picture, we observe the cutaneous, muscular, and osteoarticular territories innervated by each one of the nerves previously discussed. For regional techniques performed in the lower limb, the more distal the blocks, the more punctures are necessary to obtain a complete block. These techniques are more labor-intensive, but on the other hand, they allow us to be very selective as long as we know the anatomy in detail. The tibial nerve is a larger terminal branch of the sciatic nerve. It lies superficial or posterior to the popliteal vessels, extending from the superior angle to the inferior aspect of the popliteal fossa, crossing the popliteal vessels from the lateral to the medial side. At the inferior edge of the popliteal fossa, the tibial nerve passes deep to the tendinous arch of the soleus to enter the back of the leg. At this point, it runs caudal and medially to reach the posterior medial side of the ankle. midway between the medial malleolus and medial tubercle of the calcaneus. It terminates deep to the flexor retinaculum at the origin of the abductor hallucis by dividing it into both the medial and lateral plantar nerves that supply the foot. The tibial nerve gives off several branches to supply the back of the leg. The muscular branches supply all of the flexor compartment muscles. In contrast, the cutaneous branches, including the medial calcaneal nerve, pierces the flexor retinaculum to supply the skin of the posterior and the lower surface of the heel. The articular branches supply the ankle joint. In the foot, the nerve terminates by dividing into medial and lateral plantar branches. The medial plantar nerve is the larger terminal branch of the tibial nerve. It passes between the adductor hallucis and the flexor digitorum brevis, only to divide further, and its distribution resembles that of the distribution of the median nerve in the hand. Its muscular branches supply most of the intrinsic muscles of the sole. Cutaneous distribution of the medial plantar nerve supplies the medial sole and medial 3 1/2 toes through the fourth digital branches. Each digital branch gives off a dorsal branch to supply the nail beds on the dorsum. This nerve also gives off articular branches to innervate the bones of the tarsus and metatarsus. The lateral plantar nerve is the smaller terminal branch of the tibial nerve. It courses laterally and forwards until the base of the fifth metatarsal bone, where it divides into the superficial and the deep branches. Its distribution resembles the distribution of the ulnar nerve in the hand. Often we can find an inferior calcaneal nerve originated from the lateral plantar nerve. Its relationship to the deep fascia of the abductor hallucis muscle in the anterior tubercle of the calcaneus may explain the entrapment syndrome of the inferior calcaneal nerve, otherwise known as Baxter's neuropathy. The tibial nerve and associated vessels travel in a bundle along this pathway through the tarsal tunnel in the following order from anteromedial to posterolateral. Tibialis posterior tendon, flexor digitorum longus tendon, posterior tibial artery, posterior tibial vein, tibial nerve, and the flexor hallucis longus tendon. In the tunnel, the nerve splits into three different paths. The calcaneal continues to the heel, and the medial plantar nerve and the lateral plantar nerve continue to the bottom of the foot. The tibial nerve is the most significant in terms of innervation. It supplies most of the deep innervation of the foot, and in all foot surgery, this nerve must be taken into account and meticulously blocked. The transducer must be placed over the tibial malleolus while identifying the tibial bundle. The nerve will always be accompanied by the tibial vessels, which will help us differentiate it from the tendons that cross the tarsal tunnel at that level. Sliding the transducer cephalad will help us to confirm the nerve. This approach can be performed in plane, taking into account that approaching the nerve from the anterior may require crossing the vessels during puncture, which increases the risk of hematoma. We recommend the out-of-plane approach from the side or an in-plane approach from the posterior aspect of the ankle. It is recommended one use a higher volume of local than the rest of the nerves due to its diameter and the importance in achieving adequate anesthesia. In adult patients, we recommend 5 milliliters of long-acting local anesthetic. In this video, we can see that the vasculature is out of the way to perform our approach in plane from anterior approach. The anesthetic is deposited slowly while making sure there is homogeneous distribution around the tibial nerve. Typically, the approach should be performed out of plane from the medial or in plane from the back to avoid vascular puncture. Superficial peroneal nerve begins at the lateral side of the neck of the fibula and runs through the peroneal muscles. In the middle third of the leg, it descends between the peroneus longus and peroneus brevis muscles, and then reaches the anterior border of the peroneus brevis to enter the groove between the peroneus brevis and the extensor digitorum longus under the deep fascia of the leg. This nerve then travels superficially at the junction of the upper 2/3 and lower 1/3 of the leg by piercing the deep fascia. The superficial peroneal nerve then further divides into several branches. These branches give innervation to the peroneus longus, the peroneus brevis, as well as the cutaneous branches that supply the skin over the lower 1/3 of the lateral side of the leg and the greater part of the dorsum of the foot. The areas not covered include dermatomes that are supplied by the saphenous nerve, which is the medial side of the leg, the sural nerve, which covers the lateral side of the foot, and the deep peroneal nerve, which covers the first web space of the dorsum of the foot, and finally the medial and lateral plantar nerves, which cover the plantar surface of the foot. The examination should start from the peroneal malleus in the cephalic direction. The acoustic bone shadow generated by the fibula must be identified, and it takes a characteristic sharp fin shape. The tip of the fin marks the aponeurotic junction of the fibular muscles with the extensor digitorum longus muscle. On the surface, under the superficial fascia, and at the junction of both muscles, one or two hypoechoic structures that correspond to the superficial peroneal nerve can be identified. The approach is performed in plane from anterior to posterior while injecting 2 to 3 milliliters of long-lasting local anesthetic. In the video, we observe the acoustic shadow generated by the fibula and the fibular muscles and the flexor hallucis longus. The nerve is identified below the superficial fascia and between both muscles. Our approach will be in plane from the front of the leg and depositing 2 to 3 milliliters of long-acting local anesthetic. The deep peroneal nerve, also known as the deep fibular nerve, arises in the superior lateral aspect of the leg between the peroneus longus muscle and the neck of the fibula. The nerve moves from the lateral compartment to the anterior compartment of the leg. It then follows the course of the anterior tibial artery in an inferomedial direction. The deep peroneal nerve crosses the ankle joint, passing anterior to the distal tibia and travels deep to the extensor retinaculum. It terminates in the dorsum of the foot. The deep peroneal nerve innervates the muscles in the anterior compartment of the leg, including the tibialis anterior, extensor hallucis longus, extensor digitorum longus, and the tibiofibularis tertius. The deep peroneal nerve also innervates the extensor digitorum brevis and the extensor hallucis brevis, which are intrinsic muscles of the foot. These muscles are responsible for extending the toes at the metatarsal phalangeal joints and the interphalangeal joint. The deep peroneal nerve terminates in the dorsum of the foot as a cutaneous nerve and innervates the web space of skin between the great toe, hallux, and the second toe. The nerve is located medial to the anterior tibial artery and crosses over it at the level of the ankle joint, becoming lateral. We recommend doing the scan in reverse, placing the transducer on the anterior aspect of the ankle while identifying the anterior tibial artery and the vein. We then move the transducer in the cephalic direction until it passes over the artery, becoming medial. We will then approach the nerve in plane from lateral to medial in the most caudal part where the nerve is located lateral to the anterior tibial artery. 2 to 3 milliliters of long-acting local anesthetic will be injected. We first identify the nerve, and then once identified, the puncture is performed in plane from lateral to medial, depositing the local anesthetic as close as possible to the nerve, avoiding vascular puncture. The sural nerve is a sensory nerve in the calf region of the leg. It is made up of branches of the tibial and common peroneal nerve, the medial cutaneous branch from the tibial nerve, and the lateral cutaneous branch from the common peroneal nerve. Once formed, this nerve runs down from the mid-posterior popliteal fossa to just behind the lateral malleolus. It then travels under the malleolus and distally along the lateral aspect of the foot. At the ankle level, the nerve runs superficially between the Achilles tendon and the peroneal muscles, accompanied by the external saphenous vein. The sural nerve supplies sensation to the skin of the lateral foot and the lateral lower ankle. The nerve can be identified in the subcutaneous space located between the Achilles tendon and the fibular muscles in the lateral aspect of the ankle. Both muscles describe a characteristic shape resembling the symbol for infinity. The external saphenous nerve and vein are superficial. The needle can be introduced in plane from anterior to posterior or from posterior to anterior. 2 to 3 milliliters of long-lasting local anesthetic will be infiltrated while observing for correct spread. In this real-time video, we will be able to identify the infinity sign outlined by the Achilles tendon and the fibularis muscles. The nerve is located over the fascial plane of both muscles. The needle is introduced in plane from the posterior aspect of the ankle. The saphenous nerve is the largest cutaneous branch of the femoral nerve, and it is a strictly sensory nerve with zero motor function. It is accompanied by the great saphenous vein, descends behind the medial border of the tibia, and at the lower third of the leg divides into 2 branches. One continues its course along the margin of the tibia and ends at the ankle. The other branch passes in front of the ankle and is distributed to the skin on the medial side of the foot, as well as covering as far as the plantar aspect of the great toe. Identify the saphenous nerve as a small hyperechoic structure next to the great saphenous vein. The great saphenous vein is the main ultrasound landmark for this block because the nerve may not always be seen. Insert the needle using an in-plane or out-of-plane approach toward the fascial plane surrounding the great saphenous vein. Once the internal saphenous vein is located anterior to the tibial tuberosity, the needle is inserted in plane from anterior to posterior and 2 to 3 milliliters will be injected. Dorsal digital nerves of the foot are branches of the intermediate dorsal cutaneous nerve, the medial dorsal cutaneous nerve or superficial peroneal nerve branches, the sural nerve, and finally the deep peroneal nerve. There are 10 total dorsal digital branches. The common plantar digital nerves of both the medial and lateral plantar nerves pass between the divisions of the plantar aponeurosis, and each splits into 2 proper digital nerves. An ultrasound-guided block of the dorsal and plantar digital nerves is usually a technically difficult technique. The surface reference technique is generally sufficient and does not usually require the use of ultrasound for routine anesthesia. However, an ultrasound allows us to reduce the number of passes with the needle while depositing minimal amounts of local anesthetic very close to the nerve, and it can be extremely useful when treating chronic pain conditions. Ultrasound Doppler allows us to identify the common digital artery that usually accompanies the nerve. In this way, the out-of-plane puncture provides for adjusting the volume significantly and thereby reducing the patient's discomfort to the infiltration. The ankle block may be perceived as cumbersome by some, secondary to the need of all 5 different nerves needing to be blocked in order to anesthetize the entire foot. However, it is possible to accomplish full anesthesia for specific procedures of the foot without needing to block all 5 nerves. This anesthesia can be accomplished by blocking only 2 or 3 nerves that innervate the anatomical area where the surgery takes place. It is not necessary to use high volumes of local anesthetic, and blocking all of the 5 nerves are rarely required. In most cases, we only block 3 of them, so the total volume infiltrated does not usually exceed 15 milliliters of local anesthetic. Ultrasound allows the procedure to be carried out very precisely while reducing the latency of the block, and the preservation of ankle mobility allows for early discharge in surgeries performed in an outpatient setting. Because of the low volumes used and the minimal motor blockade, long-acting local anesthetics may be routinely used. Although it takes practice, it is a simple, fast, and reliable blockade technique. When performing procedures on the foot or ankle, we all need to know the anatomy so that we may make the adequate selection of the necessary required nerves for specific surgical procedures. If this is not done correctly, our blocks will fail. While a block of the saphenous nerve is usually not necessary for surgeries on the forefoot and toes, it is easily added if required. The sural nerve is only necessary for surgeries performed over the lateral aspect of the foot. We must first complete a proper scan of the area before inserting the needle. Since more than one puncture will be necessary, efforts must be made to minimize the discomfort experienced by the patient. Because blockade of the larger nerves requires more time for block onset, we must block the deep nerves first and then lastly the superficial cutaneous ones. Because motor blockage is limited, it is recommended to use long-lasting local anesthetic to improve post-operative analgesia. It is also recommended that the tourniquet be placed over the ankle to improve the tolerance of the surgery in case the patient awakens. The ankle block could be one of the most underrated nerve block techniques in regional anesthesia practice.